evening to everybody and greetings from India and from my institute, which is Fortis Memorial Research Institute, Gurgaon. I welcome you all for the second SAARC bone marrow transplant meeting. And the theme of today's meeting is haploidentical stem cell transplant. We all know it very well that all the SAARC countries, I would say majority of SAARC countries have started doing transplants and also have jumped into haploidentical transplant. In India, we've been doing haplotransplant for, I think, almost more than 10 years now. And in Bangladesh, in Nepal, and in Pakistan, to the best of my knowledge, people have started doing haplotransplants. So in today's meeting, we're going to have 5 talks, and we have got esteemed speakers from different SAARC countries who are going to share their experience on haploidentical transplants, and they're going to talk on haploidentical BMT in leukemias, in thalassemias, in benign hematological disorders, and they're going to talk on the infectious complications what we transplant physicians face in our day-to-day practice. So without wasting much time, I would like to invite Dr. Meenakshi Bansal and Dr. Arun Daneva to please introduce the chairpersons for the first talk. So over to you, Arun and Meenakshi. Please go ahead and introduce the chairpersons for the first talk.
So good evening all and welcome all to this second SAARC Visual BMT meets. So without wasting time, we'll start the first session. That is on haploidentical transplant in ALL and my experience of haploidentical BMT in Bangladesh. To chair this session, I would like to invite Dr. Natasha Ali. Dr. Natasha is Associate Professor in Hematology, Consultant Hematologist at Department of Pathology, Hematology, Oncology at Aga Khan University, Karachi, Pakistan. And the second chairperson is Dr. Anjali Pandit. Dr. Anjali Pandit is Consultant Pediatric Oncologist at Nepal Cancer Center, Kathmandu. So welcome Dr. Natasha and Dr. Anjali, and over to you.
So thank you very much for the introduction, and I hope we have a very fruitful talk in this session by Dr. Abu Jafar. He's going to speak on haploidentical BMT and acute lymphoblastic leukemia, and we'll get to hear his experience of haploidentical BMT in Bangladesh.
Thank you so much, Dr. Arun, for the introduction, and thank you so much, Dr. Vikas Dua, for organizing such a beautiful event. And I would like to thank all of you for giving an opportunity to attend this program. And I would like to say Dr. Abu for all the best. And we are very enthusiastic to listen to his talk. Thank you so much.
Dr. Abu, please, you can go ahead and start your talk.
Yeah. Thank you. So can you see my page now?
Yes, sir, it is visible.
Yeah, okay. So thank you, everyone, and good evening. First of all, I'd like to thank Dr. Vikas Dua. I think he's for his dynamism, and while he sent me the message, actually I was in Saudi Arabia doing the Hajj. So, but I could not content myself, to attend this wonderful, event, because as he mentioned, that haploidentical transplant, and we are all new here, most of them, and I'd like to share. So I don't have that much to say, because initially, my topic was haploidentical transplant in AML and ALL. I think in the message, but when I finally, got the topic, and it was in ALL. So I have only 2 cases, but I will share with you. I think it would be wonderful, to go ahead from this, states. So, as you know that. Sorry, there is some problem there. Okay. I cannot see my top. Okay, let's continue. So, allogenic transplant is a curable option for many hematological malignancies. The issue is the donor, because the chance of mixed sibling donor is around 25 to 30%, and in Bangladesh we don't have that umbilical cord blood bank. For unrelated donor, which is the alternative option, is still not available in our country. Still, we do not have national donor registry, and I think India, they have already. And we don't have still communication with the international registries, and transporting the stem cell from other national registry is not yet possible. So after this, we don't have that much option. So we thought that haploidentical we should choose. So many good things about the haplo, and that's why we intended and we started. And since we started, we found that it is a little bit costly, for our patients especially. It is important. There are more infectious complications, but interestingly, the chance of GVHD is much less, and almost everyone has a donor. This is the most advantage. And I was reviewing just like the haplo, the history. In 1980, the successful Hypnotransplant was done with a SCID patient. Because of the immunosuppressed condition, I think it was successful. But while it was started with the leukemia and it starts to fail, everybody had blood failure because of the immune competency. After a decade, several trials were made, like cell dose escalation, TBI, the GVHD prophylaxis. They deplete the T cells, and most of them, they had primary envelopment. They showed less number of GVHD, but it carried very high TRM, about 40%, and also very high lapse rate. And to overcome these obstacles, several strategies has evolved, like selective T cell depletion. We know some centers are doing this alpha beta depletion, adaptive transfer of the donor T cell post-transplant, and Tregs. So what happened on the other side? If we see what are the cause of this failure, and we know that it is half-masked. So the earlier attempts using unmanipulated Hypnotransplant were associated with unacceptably high rate of GVHD due to allo reactivity, as you know. And to overcome this obstacle, the key factor or the golden key came as post-transplant high-dose cyclophosphamide, which we know as PTCY. And here, I mentioned this is for my knowledge. If those who are new, they can learn from it. Very interesting things. Several milestones I mentioned. In 2020, O'Donnell, just like he showed the first use of cyclophosphamide. It was single day on day 3 and showed some success. And in 2008, Luznik, he published about 2 days, day 3 and day 4, cyclophosphamide. And then several trials happened and all showed, very good outcome about the cyclophosphamide. And here are some, references. Initial first 3 references. Those who want to start, they can read about. These are the protocols, most commonly used. The conditioning protocols. Those carries the highest number of success. And last 3 references, these are the comparisons or how we will tell or we'll know that Hypno is better. This is the article. Of course, I like to mention Bronstein. He first mentioned that, in comparison with the double umbilical cord blood, the Hypno is equal, not inferior. Then Leo published in 2014, and he showed that mixed unrelated donor is compared to the Hypno is almost equal or not inferior. Outcome are almost similar. So those who are doing mouth transplant, and they have got an alternative option of Hypno. And in 2015, he published another data that the sibling donor compared to the Hypno, the outcome of Hypno is not that inferior. It's just like very similar or very close to the optimal outcome. So the conditions are very easy, almost similar everywhere. If we see the Beijing trial or the Solomon trial, and we see that there's some ATG difference, day 3-5 or day 3-4 difference of PTCY. But these last three studies showed or gradually showing that Hypno is a very valid option for these deadly diseases. So we got an answer, and we were being encouraged and started to develop Hypno. So this is the short introduction about the Hypno. Now let me share with you about the Bangladesh situation. Bangladesh has developed in many sectors over the last 2 decades, but in hematology, especially in the bone marrow transplant, we couldn't progress that much what was actually required. In 2014, the first autologous stem cell transplant was done, first time in Bangladesh, with Mass General Hospital, USA, at Dhaka Medical College. Then in 2018, the Combined Military Hospital, Dhaka, they performed the first allogenic transplant, which was mass sibling donor. And in 2020, the Hypno transplant first time was done in Evercare Hospital, where I'm working. So these are the things that we can see. The Hypno was started just like, actually it was in the COVID. It was end of 2020. And during this COVID period, we started. So we did not get that much time to have a better, practice. I think in the short future, we'll have more and more cases. So these three hospitals actually are involved in the major BMT activities, the Dhaka Medical, CMH, and at private sector, Evercare Hospital. But I think there are some other hospitals, they are coming up already. Asghar Ali Hospital, Dr. Dilshad, while she is working, started autologous. In the BSMU University Hospital, they have the largest hematology unit, but they are a little bit left behind in the bone marrow transplant. They also started autologous. And three other very potential hospitals, like Arsenia Mission Cancer Hospital, National Cancer Institute, and United Hospital, they are coming very soon with the transplant program. I personally know that National Cancer, they got a very good government fund. They already developed the floor, infrastructure is going on, the training is going on, the machinery instrument already installed, so they will start functioning soon. Arsenia Mission Cancer Hospital, they have the space. I visited them, and there are some manpower shortage, and they are just like preparing. They will also start autologous transplant very soon. But as I said, that we need many, many more centers to cope up the situation. Now, we can see the overall data of the bone marrow transplant done nationwide till now. And don't get confused with the percentage. I'll tell you within a minute. So, and don't get confused that it is fabricated or something, because while I was preparing, I was surprised. All numbers are even. 160, 40, 30, 10, 125 looks like, it is something just like assumed, but it is the real picture. Till now, we have 165 bone marrow transplant done in our country, in the whole Bangladesh. And out of this, 125, the majority are the auto, and 40 allogenic transplant done so far. And out of this 40, 30 the mesh sibling, and 10 are the haplos. And out of this 10, 9 cases done in Evercare Hospital within last 2 years or less than 2 years, 1.5 years actually. And Combined Military Hospital, they did another one. So what is the percentage? Because as I'm presenting, I thought that I should tell you or share with you my contribution, personal contribution. So if I consider my contribution to the national level, we had 36% of the total transplant. And in the auto, it was 32%. But in allogenic, it is 58% is covering by the Evercare. Mesh sibling, almost 47%. And most of the haplos is done in the Evercare. So this Evercare Hospital, previously known as Apollo Hospital, actually 2 years before it was just like the ownership changed, so it became Evercare from Apollo Hospital. So the BMT activity in this hospital at the private level, we started in March 2016 with the autologous, of course. And so far, we performed 63 transplants, and among them, 23 allogenic and autologous 40. And this is the center that we have TBI facility in the country. Still now, this is the only center that have TBI, and it was started from 1st September 2020 during the COVID time. And out of total, we performed already 7 cases with the TBI. The conditioning used so far, the autologous are very uniform, melphalan or beam. CNS cases, we use thiotepa. And in the allogenic, it is also similar, and with the combination, different combination of the major medicine like busulfan, fludarabine, and melphalan, ATG, and TBI. Now, if we come to the Hypno, and we did it in August, exactly 30th August 2020, with the case of AML. And today my topic is ALL, so my case is only 2, and I'm coming to that point very shortly. Total number of cases 9, and the median is 20, and most of them, as I said, AML. The conditioning, as I said, it is the same as the allogenic, and we use some ATG, as actually it's not a conditioning load was ATG as a GBHD prophylaxis. And GBHD prophylaxis post-transplant as uniformly same is standard PTCY along with MMF everywhere, and cyclosporine versus tacrolimus with some patients. But there was no definite reason why the alternative was chosen. The complications overall in the transplant, I don't see that much bacterial infection. The documented infection, actually very few. We found E. coli C. diff reactivation because most of the febrile neutropenia were culture negative. The most notorious thing in the Hypno is that is Cnv reactivation. It is a very big problem in our country because we don't have phosphorate. we have only ganciclovir and valganciclovir oral. So during the recovery time, it is sometimes, we feel shaky and with the low platelet, low WBC, or in the recovering phase, giving this, toxic medications that might cause the delay of the engulfment. But, we became like helpless. And we found 2 cases of hemorrhagic cystitis, 3 cases, and 2 of them was Zika virus positive. Please do not ask me about the treatment of hemorrhagic cystitis because we just rely on the irrigation and proper micturition. That's all. 2 cases, they were difficult. We had to consult with the urology, and continuous bladder irrigation were used. And one of them settled very well, but another still hemorrhagic cystitis ongoing. Cystoscopy done, and we are using actually leflunomide. The patient has so many restrictions, like major is the financial constraint. So we cannot do that much. In a short combined follow-up of the haplo, out of this 9, 5 still alive. Death, we had 2 cases. One, relapsed on day plus 104. It was primarily, acute undifferentiated leukemia. It's a very bad case. The another one was in remission, but the patient suddenly, developed cardiac arrest. Actually came with a cardiac arrest in the ICU, in the emergency. And the patient has a history of COVID infection. So we don't know what was the reason. We could not actually find out the reason. The patient died before the proper investigation. But definitely the cardiac enzymes were very high. The patient shifted to the CCU, but within a day, less than a day, he passed away. And as I mentioned, still 2 patients are still admitted and not yet discharged. So better to say. So this is the brief overall history of my haplo in my center, actually in Bangladesh, you can say. Now, as I am confined to the ALL, I will tell you a few more things about 2 ALL cases. In the opposite scenario, the first case, a 27-year-old male, and diagnosed ETP ALL and treated with hyper-CVAD, so not a very good case, no donor. And pre-transplant stage was CR1, MRD low, but not very good. And patient was actually has financial problems, so was not interested to continue more therapy. He said if he spent money for the transplant, then he cannot continue the full therapy of hyper-CVAD. Then GVHD prophylaxis uniform, but fantastically, engraftment happened both day 14. And one thing to mention, TBI we used 12 grade, and this ATG was just low dose 2.5 milligram. And chimerism day 30 to 100%, complications still now none. So very promising. The second case, the 32-year-old male, and he is Philadelphia positive ALL. He had hyper-CVAD with imatinib. We could not give dasatinib because of low platelet count and risk of bleeding, platelet dysfunction. And even we could not continue imatinib thoroughly. And the patient also very poor, financially constrained, but he wants to be treated here and he is determined to go for transplant. So while he was waiting, he achieved complete remission, but while he was waiting for like 4 or 5 months, and he came for transplant with collection of money, and we did the BCR-ABL Philadelphia, and we found that again, it's positive. He was given ponatinib and pre-transplant, so he was CR2. MRD was a little bit better, conditioning almost the same, TBI-based low-dose ATG. And GVHD prophylaxis is almost, we kept uniform, cyclosporin, MMF, and PTCY. We are using day 3 on day 5 for all patients, but engraftment was very late. He had a Cnv infection, so on day 22, 23, count was okay, almost qualifying for recovery. But while we gave valganciclovir, even we did not have IV ganciclovir, we had oral valganciclovir, and the count went again low. But with the GCSF, finally he recovered, but his chimerism just like pending, and complications, he developed 2-3 times already CNV positive, and he has hemorrhagic cystitis. We know that this CNV many a times does not come alone. They come with herpes simplex and hemorrhagic cystitis. Urine became virus positive with a very high load, I think 4.3 or something. And we don't know what to do. He's still suffering with on and off hematuria. The problem is platelet. His platelet is below 30, 20 to 30. And whenever platelet goes below 30, he developed frank hematuria. Whenever we give some transfusion, urine becomes very clear. So we are still struggling. So these are the two opposite cases. And now, where to go and how to overcome this situation? I think, as we initially mentioned, that we have to develop the Hypnotransplant because it's the best available option in comparison to when we don't have a mass sibling donor. And we need to develop manpower. This is very important, not only hematology, other supporting subjects. And we may upgrade the laboratory, but currently we are outsourcing for all these cases, HLA, DSA, and chimerism. But good thing that drug level and viral markers and these things we are doing in-house. We have some shortage of drugs, especially conditioning chemotherapies, and as I mentioned, some viral and fungal medications. We have some shortage, and we need in our country more centers to have a better service so that we can exchange our ideas more easily and we can develop ourselves. And we can develop the national donor registry that might be helpful to get the MAD donor. And it is already been under discussion. I think our society is collaborating with somebody outside for some donation help, and the HLA typing might be available with a very low cost. I think histogenetics, they are working on it. And importantly, we need a collaboration with the experienced centers, like the way Dr. Vikas is doing, for example. And so that we can ultimately help our patients, and we can came out from this difficult situation, like cure of the malignancies and helping even non-malignant cases and helping our patients. And definitely to have a good center, we need accreditation from different national and international bodies that will give us a standard that where we are, a third person recognition is always important. I think If we can do this, and we'll be able to overcome and regarding the transplant obstacles. And with the almost COVID is, if not yet, not say bye, but I think we are not familiar with the COVID, and we are prepared to go much forward now with the transplant and hematology program, and we can extend our collaboration with the neighboring countries, and we can help our patient and ourselves as well. So with this thing, I like to conclude myself. Thank you very much for your patience hearing.
Thank you very much, Dr. Abu, for a fantastic talk and sharing your experience, what you guys are doing in Bangladesh. I think in the interest of time, we're going to move to the next session, and we'll take the questions at the end of all the 5 talks. Thank you very much.
So moving forward, the next session on haploidentical BMT in AML and my experience of haploidentical BMT in Nepal by Dr. Vishesh Sharma. To chair this session, I would like to invite Dr. Meenakshi Bansal. Dr. Meenakshi Bansal is consultant in the Department of Pediatric Hematology Oncology at Fortis Memorial Research Institute, Gurugram. And the second chairperson is Dr. Muhammad Manirul Islam. Dr. Islam is Associate Professor in the Department of Hematology at Dhaka Medical College and Hospital, Dhaka, Bangladesh. Welcome, Dr. Meenakshi and Dr. Islam. Over to you.
Good evening, everyone. Thank you, Dr. Arun, for the kind introduction. I welcome you all in the second SAARC Virtual BMT Meet 2022. So our second talk is on, for this second talk, we have an esteemed speaker from Nepal, Dr. Vishesh Sharma Pudyal. He is working as professor, associate professor and chief at Clinical Hematology Bone Marrow Transplant Unit at Civil Service Hospital, Kathmandu. He is going to share his experience of haploidentical BMT in Nepal with a special focus of on haploidentical BMT in acute myeloid leukemia. Welcome, Dr. Vishesh.
Thank you, Dr. Meenakshi. So I think can you see my slides?
Yes, sir.
Yeah.
Okay. So thank you for a kind introduction. Well, so I'm Vishesh Paudel. I'm a clinical hematologist and a bone marrow transplant physician, and I work in Civil Service Hospital, Kathmandu, Nepal. So in the coming 15 to 20 minutes, I'll be talking about haploidentical stem cell transplant in AML, and I'll be sharing my experience of performing hematological stem cell transplant in Nepal. Oh, okay. So we all understand that, and we all know that AML is a nasty disease, and it's our understanding that we need bone marrow transplant to cure most of our AML patients. So whom to transplant is not a $1 million question anymore. It's very straight and simple. We need to transplant all intermediate and high risk AML patients. We need to transplant favorable risk patients if they don't meet or if they don't achieve MRD after two cycles of consolidation chemotherapy. And we need to transplant patients who progress from MDS to AML, who progress from MPN to AML, or patient who therapy-related AML, or a patient who relapsed or were refractory to induction chemotherapy. And if you go through the recently published paper, the ASTCT recommends if you don't have a match-saving donor, then haploidentical stem cell transplant is another option. So why is that? Because the studies have shown haploidentical stem cell transplant is better than post-remission chemotherapy. Well, if you don't have a match-related siblings, then I think the haplo transplant will consolidation chemotherapy. This study was published a few years back, and it compared the and it compared transplant with matched sibling transplant. With haploidentical transplant, we can achieve lesser degree of chronic GVHD compared to a sibling transplant. So what about match-related, match-unrelated transplants? Well, this study, which was published in Blood a few years back, it has clearly showed if you use myeloablative regimen along with post-transplant cyclophosphamide, you can achieve the similar disease-free survival and similar overall survival compared to MUD. But it is not true if you're using a reduced intensity chemotherapy. If you're using reduced intensity chemotherapy, the MUD wins the race. So MUD is better than the haploidentical transplant. So, and the studies has shown, well, the haploidentical transplant have superior graft versus leukemia effect than the sibling transplant. But I want you to understand that the haplotransplant comes with price of increased risks of infection. And why is that? Well, we now understand there is a delayed immune reconstitution, and you can see in this chart, in these slides, the IL-4 and interferon gamma are much lesser in haploidentical transplant than in the sibling transplant. There are reports of increased bacterial infection with haploidentical transplant, and this is also because of delayed immune reconstitution. And as said earlier, as stated by earlier speaker, the increased Cnv reactivation is a major problem. And this is not only because of haploidentical transplant. I believe this is mostly because when we use PTCI along with haploidentical transplant, then the Cnv reactivation rates are very high. And this is also true in sibling transplant. Even in sibling transplant, if you use PTCY as a for the GVHD prophylaxis, then you also get the similar, similar incidence of CNV reactivation. So I should say that, well, the haplotransplant offers us many choices, and this is primarily not only if you look at the platform, as stated earlier, well, you have a different platforms to perform haplotransplant. The number one is post-transplant cyclophosphamide, which is most commonly used in low-income countries. And if you look at the literature published from China, well, they have their own platforms using GCSF, anti-thymocyte globulin, and then the stem cell graft from the peripheral blood and from the bone marrow. And there's another one which is widely popular in Europe and Italy, where they use the selected alpha-beta T-cell depletion transplant. Not only platforms, now we have a donor. We have a donor for each and every patient, and not only the first degree, but we can also get the stem cell from the second degree, from the cousins, from the nephews, and from almost everyone in the family. So what is our platform? What we are using in Nepal for haploidentical transplant? As we know, in Nepal, we started bone marrow transplant in 2012, and then we started doing allogenic transplant from 2016. From 2017, we are doing haploidentical transplant. So for most of our haploidentical patients, we use Baltimore protocol, but we have amended the protocol a little bit. So our TVI dose is not 200; we use 300, and then the chemotherapy is almost the same with the cyclophosphamide and fludarabine. And on day 0, we transfuse, and mostly this is peripheral blood stem cell, not bone marrow. And then and cyclophosphamide on day 3 and day 4, and followed by MMF and tacrolimus. And we also reserve the myeloablative condition for a very young patient who we think, well, they can tolerate it very well. And because when we started, we were very much eager to use the bone marrow graft, but later on, when this paper was published, and then we thought, well, because this peripheral blood stem cell it shows less relapse bone marrow graft. So we stop, and then now we try to stop tacrolimus at day 6, and we want to get rid of tacrolimus on day 19 if GVSD is not anticipated or GVSD is not seen. Were there guidelines how to select the donor, and because we are using a PTCY in most of our patients, so we go with the donor selection according to the PTCI, which has been published in published few years back. And our approach is quite simple. So we choose youngest eligible donor whenever available, whenever we have a multiple donors, and we prefer male donor rather than female donors because the study has shown that with male donor the graft rejection is low and the GVSD is low. We also we check donor DSA on every patient, on every donors, on every patient, and our threshold is less than 300, with 3,000, then we don't do any desensitization. We just take them for the transplant. And as I said earlier, we try to stop tacrolimus at day 16. So what is our experience of doing haplotransplant? So far, we have done 16 AML haplos, 4 ALL, 1 thalassemia, 1 sideroblastic anemia, 1 HLH, 2 PNH, and 3 aplastic anemia patients. And we have published our data in 2002 this year, and at that time we have done only 12 because we just included a patient up to 2020, and you can see at that time we had only 12 patients, and you can see the overall survival that's not bad either. It's like 70% of our patients were alive, are still alive, I should say. So what were the complications? Well, the complication was non-infectious fever. As we know, it's a haplo fever, was present in 86% of our patient. Primary graft failure was found in 1 patient. Secondary graft failure, both secondary to CMV, was found in 2 patients. CNV reactivation occurred in 68% of our patient. Acute GVSD was present in 22, chronic GVSD in 13, and we only encountered 1 patient with the virus. So in conclusion, the haploidentical stem cell transplant is a feasible and a safe treatment option for patients with blood disorders who require bone marrow transplant. In low-income countries, Baltimore protocol is very much cost-effective compared to other platforms. So, and this is our transplant program was highlighted in Lancet Hematology 1 year back, and you can see that our transplant cost is very cheap compared to the rest of the world. So for allogenic transplant, we charge around $10,000, which is pretty much cheap by Western standards. But again, $10,000 is not cheap for most of our patients. So when you get AML, this is what happens to most of our patients. So as I've said, this is a study done in our center. We did a survey on our leukemia patient who were under chemotherapy, and you can see, and we defined 3 different parameters to look for the severity of financial toxicity, and you can see 94% of our patients, they took some kind of help from the in the form of charity from the public or from the government. 88% of our patients, they took loans from the bank and from the other financial institution, and 87% of our patients, they sold their property just for the treatment. So we defined severe financial toxicity as two of the 3 parameters were present, and that was present in 96% of our patients. And extreme financial toxicity, if all 3 parameters were present, and that was found in 73% of our patients. So you can see that we say the $10,000 is very cheap, but again, I don't think it's very difficult for most of our patients to afford that treatment. So what can be done? Well, the government is helping. The government is providing some money for the transplant, but we thought we should do our best to overcome this challenge, the challenge of financial toxicity. So we formed a foundation called U Foundation, which helps patients by giving $2,000 to them. And then we have done MOU with the bank, which provides loan to the patient in a very nominal interest rate. And we also give a vocational training to a patient or a patient family so that they can, and we place them in a job so that they can earn some money, and which will be useful to pay the EMI to the interest to the bank. So this is what we are doing to help our patient. And so far, 8 bone marrow transplant patients, 8 patients who underwent bone marrow transplant were enrolled. We got the help from our foundations. And I think this is the way, to move forward, because at last the financial toxicity or the financial issue is one of the most, counter hindrance to proceed for a bone marrow transplant in a country like ours. So thank you very much for your patience, and I believe I completed my talk 10 minutes ahead. So if you have any questions or queries regarding my talk, I'll be more than happy to answer that.
Thank you, Dr. Bishesh, for this fantastic talk, and absolutely right. I think we have 6 minutes and we can take some of the questions. So over to you, Dr. Islam and Dr. Meenakshi. You can go ahead and put your questions to Dr. Bishesh. Or your comments, please.
Thank you, Dr. Vikash. I like to thank at first Dr. Bishesh for his nice talk, and it's my great opportunity. It's my great opportunity to be here and participate in this session. It's a very interactive and highly academic session. So I'm not the expert of transplant physician, but I know that Hypnotransplant is a very challenging cases worldwide, and it's a big challenge for the hematologic and bone marrow transplantation. And MART as well as post-transplant cyclophosphamide reduce the mortality rate and increase the success rate as well. So my heartfelt thanks to organizer as well, and please carry on. Thank you.
Thank you, Dr. Bishesh, for this wonderful talk and sharing your experience of haploidentical transplant in Nepal. It's really a wonderful talk. And what I can see, there is one question in the chat box. I think we can take that question now. CMV, it's from Professor Dr. Mohammed Mustafil. He's asking CMV-induced post-transplant bone marrow suppression in haplotransplant. If IV ganciclovir can aggravate the situation, so can only cidofovir is the only way which we can use. And any comments if graft failed by CMV reactivation, and any plan for retransplant at that situation?
Well, yeah. So thank you for the question, and you're right, because cidofovir is only the option that you have. But well, when we encounter a patient who has a CMV disease, or who just reactivated in the blood, whatever, we just start them with the ganciclovir, and we make it very sure that he also gets a GCSF with when the count starts to drop. So we don't have any other wonderful drugs. We don't have Lentivir. We don't have any other, we don't have foscarnet either. So we just rely only on IV ganciclovir or the oral ganciclovir or cidofovir sometimes. So, well, you can transplant the patient again, and we have done that on one patient. But again, the outcome is not that good. So you need to get rid of that the virus at any cost. Well, with the ganciclovir may help at times, but again, if it doesn't work, then you are in trouble.
Can I continue the question? Because do you have done the
Dr. Mustafil, I think in the interest of time, we can take the questions at the end. I think we can move on to the next talk, please.
Okay, thank you.
Okay, so the third session is on haploidentical BMT in thalassemics and experience of haploidentical BMT in Pakistan. So to chair this session, I would like to invite our chairpersons. So first chairperson is Dr. Prakash Nidhi Tiwari. He is working as senior consultant and head at Pediatric Hematology Oncology Unit at Nepal Cancer Hospital and Research Center from Kathmandu, Nepal. And I welcome you, Dr. Prakash Tiwari, sir. And the second chairperson for this session is Professor Dr. Mohammad Mustafil Karim. He's working as a professor in Hematology BMT Center at CMH Dhaka, Bangladesh. I welcome you, Dr. Mustafil. Over to you.
So, isn't Dr. Mustafil around? So I can... Please go ahead.
Thank you so much, Dr. Prakash, for introducing me. And I'm going to talk about the experience of hepatorenal transplant in Pakistan, and we will discuss some literature on hepatorenal transplant for beta thalassemia. This is a statement of disclosure. I declare that I have no financial disclosures and no conflict of interest for the material shared in this presentation. This is a brief outline of my talk. In the first part of my presentation, as I just mentioned, that I'm going to share the literature on hepatorenal stem cell transplant for beta thalassemia, and in the later part, I will share some local experience. So as you all know that in Asian countries, because of multiracial population, around 35 to 40% of patients are able to find an HLA identical donor in their families. And it is due to this reason there are a lot of international registries that have been developed around the world over the last 2.5 decades. And at present, around 25 million people have registered themselves as stem cell donors in these registries. And this has led to an increase in the probability of finding an 8x8 antigen matched unrelated donor to around 75% for Caucasians. But unfortunately, in some developing countries, the facility of donor registries still do not exist. And in that case, the only option that we are left with is to avail a 2 to 3 loci mismatched haplodonors for those patients who are in urgent need of transplantation. This donor may be a father, mother, a sibling, or a son or daughter of the patient. And the best donor can be selected on the basis of age, cytomegalovirus status, and the natural killer cell alloreactivity. And everybody now knows that very well, that the most obvious advantage of using the hepatorenal donor is the prompt availability of these donors in the family. This figure is taken from the CIBMTR database, and it represents the number of stem cell transplants in US by donor types. And as you can see here, that in the early years of transplant journey, that is in between 1980 to 2000, the most common type of transplants that were performed in US were match-related donor transplants, as shown in this blue dotted line. And this number was taken up by matched unrelated donor transplants after 2000 to between till so far. Like this is the most common type of transplant that is performed currently in USA, that is matched unrelated donor transplants. And if you see here that after 2010, like in over last 1 decade, this green bar, which represents the hepatorenal stem cell transplant, this number is gradually increasing. And this happened mainly after the introduction of post-transplant cyclophosphamide in the GVHD prophylaxis, which has actually revolutionized the outcome of hepatorenal transplant in hematological malignancies. So the two major issues that were encountered in the earlier years of hepatorenal stem cell transplant were the occurrence of severe grade 3 or 4 acute GVHD, and the other one was the graft rejection, high rates of graft rejection or relapse in hepatorenal transplants. In order to overcome these issues, 2 different approaches have been developed so far, and among them, number 1 is the T-cell depleted graft approach, in which can be done in 2 ways. One type is to use a mega doses of CD34 positive progenitor stem cells without any use of additional post-transplant immunosuppression. And this approach has been further modified now with the use of selective depletion of TCR alpha beta cells or CD19 B cells. And this approach has resulted in a remarkable reduction of the in the rates of acute and chronic GVHD, but the problem of graft rejection still remains there. Another approach which is gaining popularity over the last few years is the use of T-cell depleted grafts, along with an innovative pharmacological post-transplant immunosuppression therapy, which may be post-transplant cyclophosphamide-based or it can be ATG-based. So coming to the hepatoidentical stem cell transplant for beta thalassemia, based on the results of, in fact, based on the very convincing data arising from the outcomes of hepatoidentical stem cell transplant in hematological malignancies, there were some study groups in Europe and Asia who tried to explore this modality of treatment in benign indications like beta thalassemia and aplastic anemia. And here in this table, you can see the reported outcomes by donor type in beta thalassemia as reported in eBMT hemoglobinopathy registry between 2000 to 2010. And as I mentioned earlier, that in the earlier years of Hepro era, the outcomes were not very encouraging. As you can see that the overall survival and event-free survival, both for hepatoidentical donors, was around 68%, which was quite inferior to the matched sibling donors and the matched unrelated donors. But with the advancements in the understanding of the genetic mechanisms that can reduce the rate of GVHD and graft rejection, there's a remarkable improvement in the safety of hepatoidentical transplant in benign setting as well. This was the first study of hepatoidentical stem cell transplant in thalassemia, which was published in 2009 from Italy, and it was done by Pietro Sodani and his colleagues. In this study, total 22 patients were included, and they received a purified T-cell depleted graft with mega dose of CD34 cells collected from peripheral blood and bone marrow harvesting. And these patients, among these 22 patients, most of the patients were high risk, so therefore they were treated with azathioprine and hydroxyurea before transplant. This PTIS protocol was followed by a conditioning regime consisting of fludarabine, busulfan, cyclophosphamide, thiotepa, and ATG. And for GVHD prophylaxis, cyclosporine was given for 2 months. All patients were transplanted using maternal stem cells. And the results of this study showed that 6 patients out of 22 patients had a primary graft rejection, whereas 14 patients achieved full donor chimerism. And surprisingly, all those patients who maintained the donor chimerism, in all those patients, none had any sign of acute or chronic GVHD. So in this figure, you can see that there was an excellent outcome with an overall survival of 90% in these patients and a thalassemia-free survival of 61%, which is as good as matched unrelated donor transplant. The only concern in this study was a relatively high rate of rejection that was around 30%, and it is mainly attributable to the use of non-selective T-cell depletion. This was another paper published in 2014, and this was the, in fact, first paper which incorporated post-transplant cyclophosphamide along with pre-transplant immunosuppression in severe beta thalassemia patients. There were total 12 patients included in this study who received hepatoidentical stem cell transplant with a median age of 16 years, and 10 out of 12 patients were very high risk, and they were treated with hydroxyurea for 3 months. And this was followed by the pre-transplant immunosuppression consisted of 2 blocks of fludarabine and dexamethasone 3 weeks apart. And then they received a reduced intensity conditioning regime comprising of ATG, fludarabine, and busulfan. GVHD prophylaxis consisted of post-transplant cyclophosphamide on day plus 3 and 4 post-transplant together with tacrolimus and mycophenolate mofetil. All of these patients received T-cell depleted peripheral blood stem cells with a target dose of 7 to 10 million per kg. So 11 out of 12 patients in this study achieved full donor chimerism, and only 1 patient suffered from graft failure. And this patient received a second transplant, after which she was able to maintain a full donor chimerism. And there was a very limited acute and chronic GVHD observed in this study. And so the results demonstrated an excellent outcome in terms of thalassemia-free survival and overall survival, which were 100% in this study. Basically, this was the one study after which many transplanters and clinicians, this study led the transplanters to think and to convince them to use post-transplant cyclophosphamide safely in benign hematological disorders. Another study was published from Thailand in 2016, in which total 31 patients were transplanted. They received hepatoidentical stem cells from their parents, and basically these patients, this study also used the same treatment approach. They combined the pre-transplant immunosuppression along with a reduced toxicity conditioning regime, which was followed by infusion of a T-cell replete graft and then post-transplant cyclophosphamide on day plus 3 and 4 as a GvHD prophylaxis. This was the first study conducted in Asian population. The overall survival reported in this study was 95%, whereas the event-free survival was 94% at 2 years. So this is something very exceptional. And if you look at the data from other centers or other countries in Asian population, then this in comparison to the match-related donor transplant, these results were excellent. Recently, in 2020, an Indian paper was published in Bone Marrow Transplant Journal from the Apollo Cancer Institute, Chennai, India, in which they retrospectively analyzed the data of 20 patients who underwent hepatoidentical stem cell transplant for beta thalassemia major. And they received augmented immunosuppression along with post-transplant cyclophosphamide. So this is the pre-transplant immunosuppression that was given. It consisted of 2 blocks of fludarabine and dexamethasone, followed by the reduced toxicity conditioning. The only difference in their conditioning as compared to the previous studies that I have just mentioned was that they used a very low dose of cyclophosphamide in their conditioning, that is 14.5 milligram per kg for 2 days. And they also added a little dose of total body irradiation, that is 2 gray as a single fraction. And this study reported a thalassemia-free survival of around 75%, whereas the overall survival was 95%. And the other papers published from India showing the results of matched unrelated donor transplant were equally comparable. As we all know that the presence of anti-HLA antibodies in the recipient's serum against donor-specific antibodies, they play a pivotal role in the rejection of donor graft. So in this context, a desensitization protocol was proposed and published by a Thailand group in which they used a combination of drugs and plasmapheresis. They used rituximab, IV intravenous immunoglobulin, plasmapheresis, and in some cases, they also use HLA identical platelets at different time points, as you can see here in this figure. And this was followed by a standard conditioning regime. And they basically did a sequential monitoring of donor-specific antibody titers between these days and post-transplant as well. And this study was basically conducted in 65 patients who were supposed to undergo a hepatoidentical transplant for hematological malignancies. And they had a positive donor-specific antibodies. So what they observed in this study was that all those patients who had a very high titer of donor-specific antibodies, which was determined by a Luminex technique, and all these patients, when they were treated with this protocol, desensitization protocol, they all became negative for DSA, and the median median duration of achieving the negativity of DSA was day plus 12 post-transplant. And all those patients who had a positive DSA, they were fully engrafted for neutrophils and platelets on time. So this is another very safe approach which can be applied in case of beta thalassemia major patients who are protocol can be merged with this PTIS and reduced toxicity conditioning regime to achieve better results. So I would summarize this data by saying that novel approaches to conditioning regimes have attempted to improve the clinical outcomes of Pesaro class 3 individuals by utilizing the different myeloablative or reduced intensity conditioning treatment approaches. And with the use of post-transplant cyclophosphamide strategy, haploidentical donor source is promising for this patient population. So in the next few slides, I'm going to share the local experience of overall transplant activity and the haploidentical stem cell transplant in Pakistan. This is a patient who underwent the first bone marrow transplant in Pakistan. This was performed by Dr. Tahir Shamsi and his team at a private sector hospital in Karachi in 1995. This was the first transplant conducted in Pakistan, and it was an autologous transplant performed on a young male who was suffering from acute myeloid leukemia. Dr. Tahir, basically, he was a UK-trained clinical hematologist and transplant physician who came back to Pakistan in 1994 with a dream of establishing clinical hematology services and transplant activity in Pakistan. And with his untiring efforts, he was able to perform the first transplant in 1995. So here is the overall transplant activity between 1995 to 2020 in Pakistan. As you can see here that starting in 1995, we had only one transplant center. So the overall number of transplants was very low. But with the passage of time, as the number of transplant centers increased, the number of transplants gradually increased and it kept on rising. So far, we have done more than 3,500 transplants in different malignant and blind indications for adult and pediatric patients. Currently, there are total 11 functional transplant centers in the country, which are mainly located in the Sindh and Punjab provinces. And the existing capacity of these transplant centers is around 100,000 transplants per year, whereas the actual required number is much more. We need to do more than 10,000 transplants to cater all the existing hematological disorders. If you look at the existing Haplo BMT facility in Pakistan, out of these 11 centers which are functional at the moment, currently only 6 transplant centers are doing haploidentical transplants at the moment. And among them, the overall average number of transplants that we are doing, haploidentical transplants that we are doing in Pakistan is around 100 per year. And among these centers, there are only 3 centers like NIBD, Khan University Hospital, and the Armed Forces Institute of Bone Marrow Transplant, Rawalpindi. They are doing haploidentical transplants for pediatric indications. So if you say we are doing 100 transplants per year, then out of this 100, only 20 to 30% of transplants are offered in pediatric setting. Like in other neighboring countries, in Pakistan, the main indications of transplant remains the benign conditions like inherited bone marrow failure syndromes and hemoglobinopathies and rare genetic disorders. And this is followed by malignant indications like acute leukemia, lymphoproliferative disorders, and plasma cell disorders. This child was 4 years old, beta thalassemia major patient who received the first haploidentical stem cell transplant for beta thalassemia in Pakistan in 2017 when the official haploidentical program was established at NIBD. And his mother was his donor and he received a conditioning of busulfan, cyclophosphamide, fludarabine, and ATG. And he was offered post-transplant cyclophosphamide together with MMF and tacrolimus. And luckily, he did not suffer from any acute or chronic GVHD, and engraftment occurred on time. Currently, he is 5.5 years post-BMT. He's 9 years old now, and he's growing like a healthy and normal child. This table shows the outcome of beta thalassemia transplants from different centers in Pakistan. If we look at the outcome from individual centers that are doing transplants for beta thalassemia, the largest center and the largest number of transplants for beta thalassemia is done by Armed Forces Institute, and they are using mainly busulfan and cyclophosphamide in the conditioning along with hyperchelation therapy in heavily transfused patients, and their overall survival is around 78%. And the second highest number of transplants for thalassemia are done by Pakistan Institute of Medical Sciences, Islamabad, and they are incorporating ATG along with fludarabine and busulfan and cyclophosphamide as conditioning. So conditioning regimes in all centers are more or less same. Shifa International recently used triosulfan-based conditioning in thalassemia. And the overall survival, if you see that it ranges between 60 to 90% in all centers, with a thalassemia-free survival of 75 to 85%. This figure shows the number of transplants performed at NIBD for beta thalassemia in the last 11 years. Total, up till now, we have performed 204 transplants for beta thalassemia, and out of which 157 patients received matched sibling donor transplants, whereas 47 patients received haploidentical stem cell transplant. These are the patient characteristics of MST and haplo transplants. The median ages were very low. The youngest haplo transplant that we did in our center was 1.2 years of age, and the maximum age that we are doing is around 8 to 9. So most of the patients in our hospital which have received transplant belong to Pesaro class 2. But there were around 20% patients who were very high risk PSARO 3. That is, they have aged more than 7 years and their liver sizes are more than 5 centimeters. And this is the group of patients which is most difficult to transplant, as the rate of graft rejection is very high in this group because of heavy iron overload. So the conditioning regimes in our center are decided according to the PSARO class risk group. For very high-risk MSD transplants, we use PTIS consisting of 2 blocks of fludarabine and DEXA, along with intensive iron chelation, followed by the ATG flu BU-Cy-based conditioning. And as far as hepatorenal transplant is concerned, those patients who have a positive donor-specific antibody, they receive pre-transplant immunosuppression along with the desensitization protocol that I just discussed with you guys. And this is followed by a standard conditioning regime. And for post-transplant and for GVHD prophylaxis, post-transplant cyclophosphamide is added along with MMF and tacrolimus in all cases. So this table shows the results. Briefly, I've put the results in this table. As far as Hypno is concerned, the overall survival at our center is around 89%, whereas the thalassemia-free survival is around 75% for hepatoidentical patients. And thanks to the post-transplant cyclophosphamide approach, it has reduced the rate of GVHD to 3.7% in acute GVHD, and we did not observe any chronic GVHD in hepatoidentical patients. And this is owing to the use of post-transplant cyclophosphamide. As far as aplastic anemia is concerned, we have performed more than 15 haploidentical transplants, and these pictures are showing all the survivors of haploaplastic anemia patients. We use fludarabine, ATG, busulfan, and cyclophosphamide, low doses of cyclophosphamide as conditioning, along with post-transplant cyclophosphamide, and we prefer to use fathers as donors mainly. And at our center, the overall survival of haploaplastic is around 80%, with a relapse-free survival of 50%. And again, I would say that because of this approach, this treatment approach, the rate of acute and chronic GVHD is very low in aplastic anemia as well. For primary immune deficiency syndromes, we have done more than 25 transplants on SCID so far. And the youngest SCID child who received hepatoidentical stem cell transplant was only 18 days old at the time of transplant. This is his picture at the time of transplant, and this is post-transplant picture. You can see here clearly that he was a T, NAG, B pause, and NK pause SCID. And his father was his donor, and he received an RIC conditioning as defined in the ASID guidelines, along with post-transplant cyclophosphamide and TAC plus MMF. And after 3 months of his first transplant, his B cell counts were not fully recovered, so he required a DLI. But after that, he was doing very well. We also performed a transplant of a young child who was suffering from reticular dysgenesis. Reticular dysgenesis is basically a rare genetic disorder in which there is a dual pathology. Patient has both immunodeficiency and myelosuppression. So this patient presented to us with severe lymphopenia as well as neutropenia, and he had a gross hearing impairment at that time. So at the time of transplant, he was only 3 months old, and he was a premature child. His father was his donor. We did a PBSC using myeloablative conditioning along with post-Cy. And he was fully engrafted at 21 days of transplant, and blood counts are fully recovered. But after 3 months, his B cell lymphocyte subset was not fully recovered, so he required a DLI. After which, now he is doing very well. His donor chimerism is more than 90%. He is now 2 years post-transplant and growing like a normal child. Recently, he received a cochlear transplant in UAE for his hearing impairment, and according to his mother, he is now responding to sounds. There are some rare disorders in which we have also performed hepatoidentical stem cell transplant, like leukocyte adhesion deficiency type 1. And recently, we did the first hepatoidentical stem cell transplant for Shirdia-Higashi syndrome on a 3-year-old girl who had a history of recurrent infections and recurrent pneumonia. And her father became her donor, and we did a bone marrow harvest on him. And her conditioning was based on Thyrotipa. And post-Cy was added, of course. She is fully engrafted and sent home by the grace of God, and we hope to have her in follow-ups as well. So I would summarize by saying that we still need to increase the number of transplant centers in all provinces so that we can cater all the existing requirement of transplants. And for this purpose, we have now started post-fellowship training in BMT so that we can produce more and more BMT physicians. And we're also working on the training of paramedical staff and pharmacists in BMT. The Pakistan Blood and Marrow Transplant Group is collaborating with international societies for educational and academic growth of BMT staff. And we also aim to collaborate with international registries to start mud transplant in Pakistan. This is the list of my team members. I'm extremely thankful to all my team members who work day and night with their heart and soul to provide a better health patient care to our patients. And last but not least, it would be very unwise not to mention about my mentor and supervisor, Dr. Tahir Shamsi. He was the founder of NIBD, and he was actually the person who laid the foundation of BMT program in Pakistan. And it is because of his efforts that we are now able to treat thousands of patients with hematological disorders in our country. He was a great teacher, a great mentor, and he was the most kind-hearted person I've ever seen in my life. So God bless him and may his soul rest in peace. Thank you very much for your attention.
Thank you, Dr. Uzma Zaidi, for that excellent and comprehensive talk on BMT, haploidentical BMT in Pakistan. We were very happy to see your good results, and I hope most of our countries in this region will be able to, copy your results. Thank you. Any questions? I think we have time.
I am Dr. Mustafil Korim. It is amazing presentation from Uzma Zaidi, and very much rare transplant she did, and her team deserve very much congratulations. One question from my side to Uzma Zaidi. Are you, for the patient selection, are you getting a very early patient, or in the PESAR stage 3 stage more you are facing? And in clinical scenario, in thalassemia intermedia or thalassemia major, which patient you are more facing? Thank you.
Thank you very much, Dr. Mustafil, for your question. No, we are doing transplants mainly in beta thalassemia major, and the problem in our setup is that when we receive the patients, we mainly receive patients from the interior areas, the rural areas where there's very poor patient management. So most of the patients that are received for transplant, they belong to Pissarro class 2 or 3, and quite a lot of percentage is Pissarro, very, very high risk Pissarro group. So we are mainly doing patients who are totally transfusion dependent with heavy iron overload. That is the main patient population pool.
Thank you very much.
Thank you, Dr. Uzma, for wonderful talk and sharing your experience. It's really a great number and good results what you have shown. So I think we can move forward to our next session, which is on infectious complications in bone marrow transplant, haploidentical bone marrow transplant. So to chair this session, I would like to invite Dr. Rahul Bhargav. He is the Principal Director and Head in the Department of Hematology, Oncology and Bone Marrow Transplant Unit at Fortis Memorial Research Institute, Gurugram. Welcome, sir. So second chairperson for this session is Dr. Meet Kumar. He is working as a senior consultant in the Department of Hematology and Bone Marrow Transplant Unit at Fortis Memorial Research Institute, Gurugram. So I welcome you all, and over to you, sir.
Thank you, Dr. Vikas, for organizing this virtual BMT summit and second SAARC summit. I congratulate you all for your efforts. It's a very, very important thing as we are moving towards better survival and the willingness of the people, and with the shrinking world and the smaller families. We know that we might not have donors. So my mother had got 7 brothers, sisters. I have got 1, and my son doesn't have. How do we get a bone marrow transplant done? And that's where the Hypnotransplant comes in. Whether it be sickle cell, whether it be thalassemia, whether it be leukemias, these people deserves bone marrow transplant. And right from the conditioning regime to the post-transplant viral infection management, it's an art. It's a learning curve, which Dr. Vikas and team in pediatrics has gone a long way in thalassemias and sickle cell with 88% survival rates. So very interesting to listen to the newer advancements in the field of haplotransplants with a reality that today everyone who's suffering from a blood disorders can get a transplant, haplotransplant done, and can live longer with a good quality of life. Over to the Dr. Meet and Dr. Vikas.
Dr. Meet, your comments, please, and you can go ahead and introduce the speaker.
I think without wasting much time, I'll just introduce Dr. Neha Rastogi. I think the role of infectious disease specialist in a transplant physician is unsurpassable. And the role that Dr. Neha plays as a part of the transplant team is commendable. So I welcome Dr. Neha Rastogi, consultant infectious disease at Fortis Hospital, Gurgaon, to shed some light on infectious complications in haploidentical setting, especially. Welcome, Dr. Neha. Are you there, Dr. Neha?
Thank you.
I'm not sure whether Dr. Neha is there. Dr. Neha, are you there?
She is joining, sir. I just spoke to her.
Okay.
when we are dealing the case of the hematopoietic stem cell transplant, specifically for the haplos. So this is a graph from the BMT which shows that how there is a difference between the complications in allo, that is allogenic, versus auto HSCT. So we can clearly see, if I can show you a pointer through, so we can clearly see that the viral infection risk is quite high as compared to into the auto stem cell transplants, followed by bacterial and then fungal, whereas bacterial in general is quite high in majority of the transplant settings, specifically in the pre-engraftment period. So this is a paper from the 2019 BMT paper from the Stem Cell Society of the Transplant, and they have seen almost 381 plus patients across 30 centers with 1,000 plus episodes of infection. And they have found out that almost 40% of the infections are viral in origin, of which CMV is of the most important, nearly half of the infectious profile. So if you see the infectious profile in the HSCT, this is another paper which shows actually a review of literature into different kinds of the papers across the globe, which have reviewed the literature in terms of the infectious complications in the haploidentical settings, specifically with the T-cell replete settings. That is something which we also follow, that is PPCY setting. So overall, the infectious risk is quite high, if you see. And in terms of the etiological profile, we can say that the viral, followed by bacterial, fungal, and rarely the parasitic infections have been seen in the etiological profile. If you see the days plus SCT in terms of the median time of occurrence of these etiological infections, so like we said that pre-engraftment, most of the people have lines, they have a hospital stay. So majority of times the bacteremias or the bacterial infections are bound to occur in the pre-engraftment phase. So virus usually hovers around the engraftment to post-engraftment phase. Fungemia happens in both, just that the etiological profile may vary from a pre to a post-engraftment phase. So this is a paper from the Indian setting showing the single center experience from CMC, where they have seen the 257 haplo patient over a period of 10 years, showing the 122 children also as a subset. And they have the 90% having either one or the other documented infection. So across of them, 45 plus of bacterial, 70% viral etiology, and 38% fungal infection has been found. So if you see our data, so this is a data of a preliminary last 10 months data, where the adult and pediatric combined, we had a haplos of almost 32 in number, and almost in agreement to any other Indian settings, we have the 71% infection profile. Either one of the infection is there, of which we have a culture proven bacterial infections in 37%, proven fungal infections either by the histological diagnosis or by the candidemia in the blood culture in 6. We have viral in 62% with 20 or more with the different kind of viral reactivation. I'll come to that in the subsequent slides. Overall, the mortality rate was 25%. And if you say attributable to the sepsis, it's almost 15% of these patients. So I just want to highlight a few important points when we deal with the different etiology of infections for the paucity of time. So we all know that in bacterial infections, we have nth number of bacteria which are responsible, especially in the transplant phase. So just to have a hint, that is a bloodstream infection, because most of the times the lines, the CVC or the PIC line, they are considered to be the culprit. They are quickly colonized because of the multiple manipulation, and especially with the risk factors, because prolonged severe neutropenia is there when we are talking about the haplotransplants. There is a severe mucosal damage. You have also sometimes concomitant a GVHD coming up, further ruining the infectious complications. So one important point in this is the gut microbiota. So nowadays, a lot of research is happening that how you can modulate your gut microbiota, not only to prevent the GVHD per se complications, but you know, the lesser the risk of GVHD, the lesser is the mucosal damage and lesser is the transmigration. The ultimately upset will be the lesser bacterial bloodstream infections because of the secondary superadded gram-negative translocation. So just by eliminating the lactobacillus, which is usually a scenario in the transplant settings, causes GVHD. So somewhere or the other, if we replenish this normal flora, we can have a reduced risk, or rather the prevention from the GVHD focus, which is one of the important commensal also, or a colonizer in our abdominal gut. They have been found to be more in the escape mechanism, probably because we use a lot of broad spectrum antimicrobials, mainly covering the gram-negative. And since there is a lot of gut dislocation, enterococcus tend to become an escape pathogen and arise eventually. As far as the MDRO, which is a major concern I press across all the SAARC Asian people, all the transplanters out there, that majority of the patients have the multi-drug resistant localization already. So since they have been in and out in the hospitals pre-transplant also many a times, because it's an haplo after all, they are either colonized with the gram-negative also, or many a times they hibernate or they inculcate the bacteria during the pre-engraftment and eventually causing the further problems. So this is our data. So of 22 culture positive vis-a-vis biofire positive isolates, we have the MDRO in almost, so these are the 22 MDRO positive data. So of which, if you see the molecular epidemiology, why it is important, I'll just share in a second, that, you know, the OXA and NDM, they are the two important genes which are responsible for the major carbapenem resistance enterobacteriaceae. So that only implies that most of the time we use the colistin, or most of the times these days we are using the ceftazidime, avibactam or astronam, how to modulate their role in the transplant settings in the presence of this molecular epidemiology. We also have the nasal and rectal swab colonization culture being there followed. So we have been following the rectal swab using pre-transplant to see the colonization rate. And to be surprised, or rather to be on a gloomy side, the CRE, the carbapenem resistance enterobacteriaceae colonization per se is nearly reaching 37 to 40% in there. Another important point in the bacterial infection, these are important snippet points because these are something which hover every transplanter day in and day out, that how to diagnose, rather how to track whenever there is a fever. That are we giving more on the doom side of the antimicrobials? Do we switch to antifungal? Do we think about the other non-infectious complications? So important highlight is the procalcitonin. So outright and center, we order this test that has a procalcitonin, how the value fares in the neutropenic period. So this is a beautiful paper which shows that how in a procalcitonin in a neutropenic period, specifically after the allogenic HSCT in almost 200 plus febrile neutropenic patients, if the procalcitonin value reduces by 80% in 5 to 7 days, the outcomes are pretty good, more than 90%. But if there is an inability to decrease the procalcitonin by more than 80% in the 5 to 7 days after the onset of fever, that has predicted the poor 100-day survival. Another important point, like in the beginning only I have mentioned, is how will the infections overlap with the CRS. Because, you know, the cytokine release syndrome is a very broad spectrum clinical syndrome. So that usually happens. So that time when there is a fever and fever continuously, so that time, many a times it can be overlapped or rather super added by the bloodstream infections. And they have seen when there is a grade 3 CRS, that is continuously mucosal damage is happening and the cytokine release is to the maximum extent, it has been seen that it is independently associated with bloodstream infections. Nevertheless, we will, in benefit of doubt, add the antimicrobials empirically. And now there are enough data literature to prove that if you have a CRS phase passed, and if after 5 days the cultures are negative, the fever has subsided, we can safely de-escalate the antimicrobials, irrespective of the anticipated neutropenia, which is going to be there, or irrespective of the negative cultures which has happened at the time of CRS. Now coming quickly to the fungal infection profile, We all know that the fungal infections, nevertheless, is another trouble infection. So there is always a lower probability as compared to the viral and bacterial, but still they are there in the picture. So in our center, we have seen, like I mentioned, that 6 proven fungal infections were there. 3 are the Candida species, of which 1 was a very disseminated and a resistant Candida auris in a pediatric kid. And 3 of them are in the mold proven infections, 2 mucormycosis, 1 aspergillosis. And as far as probable is concerned, because majority of the times we have a clinical radiological diagnosis of the fungal infection, and eventually sometimes in some cases we'll proceed ahead with the bronchoscopy, which is itself is a very troubling in the terms of the offset of a neutropenia as well as thrombocytopenia. But we found out to be having a 2 bile galactomannan, which were quite positive. So just a brief about the use of isavuconazole, that's a newer antifungal on the block in the terms of the HSCT transplant as a primary aspergillus prophylaxis. So there has been enough data now to share that the isavuconazole can be one of the ideal candidates in terms of reduced interaction, no hepato, no renal toxicity. The major constraint in our Asian countries is its cost, of course. And then there is limited data on the breakthrough infection. This is the review of literature because there has been an off-label use of isavuconazole in the pediatric patient profile. Because majority of the studies of isavuconazole are in the adult patients. So there has been now a range of data which is coming across and how we can use the isavuconazole in the kids as well in the hematopoietic stem cell transplant. Vis-a-vis, this data also includes the malignancies as well. So coming to another important point of a therapeutic drug monitoring. So wherever across the nations we use voriconazole or posaconazole, which is most common prophylaxis, if we are talking in terms of the haploidentical. So with lot of drug interactions being combined, lot of concomitant drugs being given, how we ensure that the antifungal are actually being dealt in the value. So like all you for transplanters, we have a cyclosporine levels being monitored eventually to see whether the immunosuppression is in control or not. Same way, the antifungal drugs have their own therapeutic drug monitoring profile because they don't follow eventually a very steady pharmacokinetics. So we have a Tdm monitoring available at our place also. So this is in total we have done in post-BMT settings, even in the follow-up, 78 plus TDMs have been done in the last 7 months. And we have found out that amongst them, 4 have found out to be a suboptimal levels, 3 of posaconazole, 1 of voriconazole, and 1 had a proven breakthrough fungal infection. So understand one thing, when we give a patient of a voriconazole, for example, there are a lot of PK/PD characteristics involved related to its absorption. And many a times when we see a radiological infiltrate, we say that it's probably a fungal have arisen on the voriconazole, and the next eventual thing is to jump to another higher antifungal. With the TDM in place, we can have a more rationalized use, we can have a more better definitions and delineation in terms of actual breakthrough infection, so as to save on the usage of antifungals. Now coming to the viral infections, which is a very important danger signs in terms of the HSCT, both pre, post, especially post engraftment, and goes up to even 100 days and beyond. So this is a paper from they have used the PTCY regimen. They have used in 236 odd adult patients who have received this PTCY regimen, and they have seen that the invasive, the viral infection risk was almost 69%, eventually leading to the highest in the terms of the viral reinfections, followed by the other etiological profile. So in our countries, in our set of countries, there is nothing a terminology. There is a very rare term if you call it as a CNV infection. So most of the time, we are actually dealing with CNV reactivation because considering the 99% plus zero prevalence in our settings, the most probable is the CNV reactivation. So there has been enough data from the Indian settings which shows the CNV reactivation in the variable range from 40% to up to 70% reactivation risk. If you see in our profile, we have an overall incidence of 60% plus reactivation of almost all the viral infections, of which CMV has nearly 50%, BK, EBV, and we also saw one case of HSV2 myelitis in one of the patient received the haplo transplant. So one important point in terms of the preemptive treatment is that it is not always a golden glow for the ganciclovir. So there has been a good data. Even our institute have also published a data which we have shown that there is no significant difference in terms of CMV clearance as well as the treatment duration and a breakthrough CMV viremia who have received either a valganciclovir, which is oral, easier to use, easier to monitor at home, and a very good compliance, followed vis-a-vis with ganciclovir as a comparison. Now, one important point in terms of haplo is the very danger for having a CNV reactivation. So for that, the letermovir prophylaxis has been there, which has been approved and being used outright and center for the high-risk allogenic transplants, which has been found to have a significantly lower risk of clinically significant CMV infection. So as this NEGM trial has already shown that how it clinically reduces the CMV reactivation at 24 weeks and eventually at 48 weeks, which has been just published. At our center, we have used in 5 patients in the haploidentical transplants, and of which only 1 patient had a breakthrough CMV viremia on the subsequent viral loop. One important strategy in treatment, because in the CMV treatment, majority times the treatment lies in the arm of either a ganciclovir vis-a-vis valganciclovir. Most of the time for treatment, we prefer the injectables. Cidofovir data is usually being limited to the salvage therapy. But we have used cidofovir upfront line in our patients because cidofovir has an advantage in terms of the better coverage for both CMV and BK virus, even adeno as well. Second, cytopenias. That was always a nightmare for all the transplant people, that when you use a ganciclovir or valganciclovir, either it's a CMV which is causing a marrow dysfunctioning or it's a drug-induced marrow dysfunctioning, we are never able to sure, and we always anticipate it to be a drug-induced. So cidofovir is usually free from those side effects. The only thing is that it is an IV once a weekly and it has a nephrotoxicity attached to it. One of the important limitation I should mention is that it has no much role in the organ involvement or a CMV disease per se. So we had used cidofovir upfront first-line therapy in our 28 patients. That includes all transplants, of which the haplo 6 patients were included. We have found out the breakthrough CMV viremia in 10 patients. And in our observation, we have seen if the CMV viral load is approximately less than 50,000 to 75,000, 2 to 3 doses of cidofovir suffices almost all the CMV viremias. Whereas in few of the patients, if you have a concomitant GVHD, if you have issues with the cyclosporin levels, so sometimes it has been seen that the breakthrough occurs either in the form of a CMV disease or a continuous progression of the viral load, eventually leading to the usage of ganciclovir. As far as the salvage therapies are concerned, there is also a role of leflunomide and artesunate also there. However, in our experience, we have seen that artesunate is usually in the patients who have a very vulnerable graft dysfunction. The hemolysis risks increases. And as far as leflunomide, though it's a good immunomodulator agent, itself contributes to the bone marrow suppression. Now, the future lies in the whole that we always measure the viral load. Time to measure the CMV-specific cell-mediated immunity by something like a IGRA or an ELISpot, something which we use in the TB manipulations as well. Second last slide being the BK virus. So how can we forget the BK virus after being from the CMV? So we all know that BK viruses, BK viremia itself is not a major issue, but then the BK hemorrhagic cystitis leading to the seepage of the platelets, and that vicious cycles go on and on. And even the BK virus eventually leads to at times the graft dysfunction as well. So there has been enough studies on the drugs and the agents for the BK virus prevention as well as treatment. But one particular point to note, keep your platelet count above 50,000, have an IVIG in place. You have to have a once in a 3-week IG levels to be monitored, especially in the haplo people. And the low dose cidofovir data is still coming up, that is at 1 mg per kg in the symptomatic BK virus hemorrhagic cystitis, which has now been seen to have some role in the placement of the BK hemorrhagic cystitis. Respiratory viruses, of course, they are also important, specifically the RSVs, the influenza. We have also encountered 4 episodes of the URTI in the post-haplotransplant who have eventually landed up with the URTI respiratory panel being positive either for RSV or the influenza. Since they are treatable, they have a specific antivirals. So it's important to look out. It's not common usually in the haploidentical and terms of the different viral aspects, but yes, it is very important in the terms of causative pathogen and a treatable point of view. Last but not the least, COVID with the HSCT. So with the era which we are living in and eventually subsequent down the line, the COVID variants will come, keep and going, but our HSCTs, the haplos won't stop. So we have to make sure that how to have a patient community and a healthcare staff with the environmental factors, specifically in terms of the infection prevention, the HEPA filters, how to screen for even your donors as well. So this is very important when we are dealing in the haploidentical transplants or rather any transplant in this COVID era. In terms of the medical profile of these patients with the concomitant COVID infection, so we had 2 patients with COVID in the haploidentical transplant, and one got COVID in the pre-engraftment phase just after conditioning. That led to the marrow recovery, which we saw in this particular patient. However, since this data is very limited, that what are the outcomes of particularly the transplant in the process with the active COVID, so that data has to be needed from the different profiles, different angles to have a proper regimen and rather the profile in terms of usage of the remdesivir or any other antiviral in these patients. So thank you all for your patient listening. Thank you.
I'll say comprehensively covered, extensively, I'll say discussed, and well within time. Do we have any time for questions, the organizers?
Yes, Dr. Meet, please go ahead.
So I don't think there is any question in the chat box, but in the interest of time, I'll just take one question. We have the access and availability to the molecular analysis of infections. So that has helped us, or it has been a curse in today's setting. So as in like we are identifying, over-identifying the infections that have little relevance, or we are actually able to guide the therapy based on the molecular analysis for infections. That's what the question to you, Dr. Neha.
Right, sir. So it's actually a boon or a bane that depends upon what settings you are using in. Of course, settings I meant to say the sample setting. So what sample you are using, number one. Second is just the mere detection of the organism is not the job completed. So for example, if we give a BAL, that is a bronchoalveolar lavage fluid, just the presence of the Acinetobacter DNA doesn't serve any purpose. Rather than the count of that bacteria is more important. Whereas the similar profile, if you see in a blood, which is considered to be a sterile site, the presence of DNA itself, when nothing is coming out in any of the cultures, that makes some more sense. So the type of sample, the type of pathogen DNA which we are detecting. So for example, in the biofire upper respiratory tract, we have nth number of viruses, like I mentioned in one of the slides. The presence of a common cold virus or a rhinovirus won't help us in much. But yes, the RSV DNA being detected, you have a treatable thing. So it's the idea, what are you interpreting and which sample you are giving the test. That is more important.
Perfect. Any other questions from any of the audiences or the faculty? I think if there are none, then probably we can hand back to the organizers, and thank you once again for this wonderful session.
Thank you, Dr. Neha, for the wonderful talk and highlighting the various infectious complications which we face during the transplant. So without wasting much time, we are moving ahead to our last talk, which is haploidentical BMT in benign hematological disorders and my experience of haploidentical BMT in India. So to chair this session, we have with us Dr. Arun Dhaneba, who is working as consultant in pediatric hematology, oncology and bone marrow transplant unit at Fortis Memorial Research Institute, Gurugram. Welcome, Dr. Arun. And the second chairperson to chair this session is Dr. Sudhir Sapkota, who is working as consultant at Kanti Children Hospital at Kathmandu, Nepal. Welcome, Dr. Sudhir. Over to you.
I think Dr. Sudhir couldn't join because of some technical issue. So, Dr. Arun, you can just start the session.
So, it is my privilege to introduce Dr. Vikas. Dr. Vikas doesn't need any introduction for this audience. So, Dr. Vikas is Director and Head of Pediatric Hematology Oncology in the Bone Marrow Transplant Unit at Fortis Memorial Research Institute. And sir is going to discuss about the haploidentical BMT in the benign disorder and how he established this haploidentical program in our unit and the challenges he faced. Over to you, sir.
Just 1 minute. Just give me 1 minute. A very good evening to everybody and friends. I think it's a wonderful time and a fantastic time that all the neighboring countries, all our colleagues in SAARC nations have started doing haploidentical transplants. And as we are gaining more and more experience in haploidentical transplants, the outcomes are also getting better. So friends, in next 20-25 odd minutes, I'll be talking on haploidentical transplant in benign hematological disorders, and I'll share my experience of doing haploidentical transplant in my hospital, which is Fortis Memorial Research Institute. So in India, we have, I would say, more than 80 odd centers who are into transplants, and there are, I would say, 15-20 centers which are doing haploidentical transplants. So it is difficult to gather individual data on haploidentical transplants from India, but I'll be sharing my experience of haplo in my hospital, which is Fortis. So friends, as we see, the indications and numbers of transplant for non-malignant disorders are increasing day by day. So when we say non-malignant disorders, we are talking about bone marrow failure syndromes, hemoglobinopathies, primary immunodeficiencies, and so forth. So we need to have more and more expertise in doing transplants for benign hematological disorders. So friends, benign and malignant, they look very much similar, but they are definitely different. The reason being, the mortality acceptance is quite poor in benign disorders. So if somebody has got a child, I'll give you an example. If somebody has a child who's got thalassemia versus somebody who has got a child who's got leukemia. So for a benign disorder, nobody would like to lose the child. Definitely nobody would like to lose the child either for leukemia or for thalassemia, but the mortality acceptance is quite poor in public, especially in developing nations in benign disorders. And we have a smart immune system in benign disorders, like in thalassemia. These patients are being transfused blood multiple times. From the age of 6 months, they have been getting multiple blood transfusions. They have received blood from different donors. They have formed more and more HLA antibodies, and there are more and more chances of rejections in those cases. And then when you talk about thalassemia or aplastic, and as these patients have received blood transfusion multiple times, there's always a risk of iron overload in the liver and definitely veno-occlusive disease. But in general, I would say the outcomes are better when you talk about benign disorders as compared to malignant disorders. So if you don't have a matched sibling donors, we all know that there is a 25 to 30% chance that your sibling would be matching to you on HLA. What does this mean? That means that if you have 100 patients who require transplants and they have got siblings, 25 to 30 would be lucky enough to have a full match donor in the family. But what about the rest, 70 to 75? Either you can search the donor from outside the family, which is called unrelated donor transplant, or you can go ahead and do a unrelated cord blood transplant or a haploidentical transplant. When we say people of SAARC nations, the probability of getting I would say a full match donor from a related family member or an unrelated registry is around 41%. Whereas when you talk about people of, I would say, African origin, Caucasians, there is a 77% chance that you may get a unrelated donor for them. So what does this mean? This means that in India, in Asian countries, there are less chances of finding a full match donor, and there is a high need. There is, I would say, more need of doing alternate donor transplants in the form of haploidentical transplants. What are the two ways? So our previous speakers have already touched on this. Either it is a T-cell depleted transplant or a T-cell repleted transplant. So majority of the centers in India, or when I say in SAARC nations, are doing T-cell repleted transplants, and among these centers also, majority of them are using PTCY, post-transplant cyclophosphamide-based approach, whereas Chinese people are using, I would say, heavy immunosuppressive therapy medicines for doing haplotransplant. They're using Beijing protocol. But when you talk about T-cell depletion, there are ways of doing T cells. There are ways of depleting the bad cells, culprit cells. One way is a positive selection. You collect the stem cells, and out of those stem cells, you collect the CD34 cells. But there are issues. If you're not giving NK cells, gamma delta cells, there are more chances of infections. There are more chances of rejection. That's why you require better techniques. So nowadays, people in India, those who are doing T-cell depleted transplants, are doing T-cell alpha beta depletion with CD19 depletion. What does this mean? This means that T alpha beta are the bad cells, which cause GVHD. So you deplete the T alpha beta cells and give T gamma delta cells along with NK cells and the dendritic cells to help in faster engraftment, to help in fighting infections, to having, I would say, less chances of GVHD for these patients. What are the pros and cons? The only pro for a haploidentical transplant is that each and every patient has got a donor. And with more and more, and I would say, expertise, by doing more and more transplants, the outcomes have improved even with PTCY based approach. And the donor is immediately available. You don't have to wait for the donor. Like if somebody has got a bad leukemia, the moment you get the patient into remission, and if that patient doesn't have a full match donor in the family, you don't have to wait to look for an unrelated donor. You can immediately go ahead and do a haploidentical transplant by taking a sibling, parent, or I would say a cousin as a donor. And I would say cost is more or less similar in the first 3 to 4 weeks when you are actually doing the transplant. God forbid you don't land up in a trouble, you don't land up in a complication, then the cost can go up. But the cost is similar for the initial 3 to 4 weeks. What are the cons? The ultimate challenge, there are more alloreactive cells. So if you're doing a PTCY based approach, still you may miss some cells. You may miss some T cells, which can cause GVHD. So the chances of GVHD, rejections, chances of TRM because of infections are high. If you do a T cell depleted haplo, there is a slow immune recovery. That means more chance of infections. So these are some of the cons when you talk about haploidentical transplant. Dr. Usma has touched upon haploidentical transplant in thalassemia. So I'll not be talking much on thalassemia, but we all know it very well. This is the person, Dr. Thomas, who did the first successful transplant for thalassemia, and he got a Nobel Prize in 1990 for his work. And he used a busulfan cyclophosphamide-based approach in 1980s to do the transplant for this patient who had thalassemia. was at that time was 16-month-old. And the beauty was that that patient who underwent a transplant in 1980s is still alive, is around, I would say, 42, 43 years old and living a normal life, a blood transfusion-free life, a thalassemia-free life, I would say. After that, there have been a lot of publications which have come up for thalassemia transplants, especially when you talk about matched sibling donor transplants. So these are some of the publications which have come up on thalassemia transplants, but mainly were matched sibling donor transplants. And this was a paper published by, I would say, Lucarelli in 2002, in which he claimed a cure rates of close to 73%. Overall, I would say, overall survival of around 73% across all Tesaro classified patients. When we talk about haplo in thalassemia, there are 4 ways, I would say. You can use a Hopkins-based approach like fludarabine, cyclophosphamide, TBI, and you can add thiotepa. You can use fludarabine, cyclophosphamide, a low dose of TBI in the form of 4 grays. You can use a Thailand protocol, which Dr. Uzma shared, 2 cycles of pre-transplant immunosuppression followed by ATG, flu-bu, or you can use a MAC protocol in which trio flu thiotepa or blue few thiotepa is being used. Dr. Usma has already touched upon this paper, so I'm not going to discuss this. Let's move on to the next papers. This paper is also being discussed by Dr. Usma and was published by Dr. Suradesh from Thailand, which talks about haploidentical stem cell transplant with pre-transplant immunosuppression followed by reduced toxicity regime and PTCY for severe thalassemics. So 18 patients who underwent transplant, 10 were male, 8 were females, median age was 16 years. 10 out of 18 were high risk. 3 of these patients received hydroxyurea at a dose of 20 milligram per kg for at least 3 months before transplant. A fantastic outcome. 16 out of 18 engrafted with full donor chimerism, which was 100%. 2 patients suffered graft failure, event-free survival and overall survival of 95%, and a median follow-up of 12 months, which ranged from 4 to 20 months, is what they showed. Similar publication by the same group, around 31 patients, 17 male, 14 female, around 15 were high risk, class 1, 7 patients, class 2, 9 patients, donors were parents, either mother or father, and 2 cycles of pre-transplant immunosuppression followed by ATG, flu-bu, with PTCY and cyclosporin/tacrolimus with MMF was used, just 1 rejection and 1 death. And 5 patients had mild to moderate VOD, all managed with supportive care. 9 patients had grade 2 acute GVHD, which resolved with steroids. Only 1 patient severe grade 4 GVHD, and 5 patients developed limited chronic GVHD. And I would say, friends, this is quite fantastic. For these 31 patients who underwent haplotransplant, just 1 patient had bad GVHD and 5 had limited chronic GVHD, just 1 rejection and 1 death. OS of 95% with thalassemia-free survival of 94%. So this is a publication from India, and a similar sort of protocol is what we've been using in our practice. In this, Apollo Chennai group have published data of around 20 patients from August 2017 to August 2019, and all children received pre-transplant immunosuppression for around 6 weeks in the form of 2 cycles of Fludex, similar to what Thailand people used. Hypertransfusion and chelation was given. Conditioning was different. So it was fludarabine, cyclophosphamide with a low dose of TBI in this, and they added thiotepa. So similar sort of thing is what we've been using in our practice. Acute hypertension was seen in 5 patients. Bacterial infections was seen in 8 patients. Viral infections in 3 patients. 3 had graft rejection. Out of 23 had graft rejections. Some viral reactivations in the form of CMV, adeno, BK was seen. So that was, I would say, quite in a number. I would say 60% patients had viral reactivations. Grade 1, grade 2 GVHD was seen in 4 patients. which is 20% of the total cohort, and limited chronic GVHD was seen in 20% patients. Immune cytopenias was seen in 15% patients. The disease-free survival of these 20 patients was around 75% and an OS of around 95%. So friends, in our experience also, we have used similar sort of protocol for almost, I would say, 18 odd patients, and almost, I would say, 14 patients are doing well. Just 2 had rejections, but we saw some GVHD, acute GVHD, and chronic GVHD in our cohort of patients. So this is the patient characteristics. I think we should not go into a detail of this. Just look at this. A thalassemia-free survival of 25% and an overall survival of 100%, what this group has reported, which is fantastic. I think this we have already discussed. We should not go into detail of this. Let's move on to the next slide. So BMT remains a choice for those patients who are receiving safe blood and chelation. Family should be explained the risk and benefit of both the options. If safe blood and chelation services are not available or accessible, then BMT should be strongly encouraged, and all sources of stem cells, including haplodonors, should be considered to treat thalassemia major patients. So there are quite a number of times when these families come to us that we don't have a full match donor. What should we do? So we explain them in detail about unrelated donor transplant or a haploidentical transplant, and then we leave it to the family to decide whether they want to go ahead with an alternate donor transplant for a benign disorder like thalassemia or not. When we talk about severe aplastic anemia, we all know it very well. In majority of the SAARC nations, we've been either using ATG with cyclosporin or a matched sibling donor transplant for severe aplastic anemia. But but we need to understand, though there is a 90% chance of cure or overall survival with a matched sibling donor transplant, with the use of ATG and cyclosporin, only 60 to 70% patient respond, and not each and every patient would have a complete response. Then what are the options left? Either you can go ahead and do a matched unrelated donor transplant, or you can go ahead and do a haploidentical transplant. So friends, we need to understand that there are times when patients, they come to us in bad infections, in bad shape, I would say with bad fungal, bacterial infections, and they don't have time that you give them ATG, cyclosporin, and then you wait for 3 months for the cyclosporin ATG to work. So in those cases, we strongly recommend, I would say, a haploidentical transplant. But what about the naive patients, the treatment naive patients, whether they should go ahead with a haploidentical transplant or not? That's what we are going to discuss. So this retrospective study they collected the data from 1976 to 2011, 82 transplants in 73 patients, myeloablative conditioning, ex vivo T cell depletion, median age was 12 years, 58% patients engrafted, almost 1/3 had acute GVHD, 25% had chronic GVHD. So results were not very great. So we need a better approach, a new approach. So this is what we've been using in our practice when we do a haploidentical transplant for a idiopathic aplastic anemia patient. You give ATG at a dose of 4.5 milligram per kg. Then you give fludarabine, the conventional Hopkins, fludarabine, cyclophosphamide. Then rather than giving, I would say, 200 grays of TBI, we use 400 grays, cyclic grays of TBI for treatment naive patients. For the relapse refractory patients, we use 200 cyclic grays. For the treatment naive patients, we use 400 cyclic grays, and we use cyclophosphamide on day 3, day 4 post-transplant, and we give tacrolimus with MMF. And what we do in our practice, we target, I would say, a CD34 dose of 5 million per kg. So initially, this group was using 200 cyclic grays even for the treatment naive patients. For the initial 10 patients, they were using 200 cyclic grays. So they had 3 graft failures. 3 graft failures out of the 10 patients. So they modified. For the treatment naive patients, they increased the dose of TBI and the graft failure rates went down. And a similar sort of thing is what we've been using. and the overall survival and the event-free survival are quite phenomenal. If you look at their results, treatment naive patients, 86% overall survival and overall survival of 100%. So, friends, I would say that Haplo is a reasonable and should be considered as an option upfront also for treatment naive patients, and definitely for relapsed refractory patients when you don't have a choice. Haplo should be done for each and every patient of idiopathic aplastic anemia. Coming to Fanconi's Haplo, I personally feel when we talk about Haplo in Fanconi's, it's a nightmare for a transplant physician. Even if you reduce the dose of cyclophosphamide, even if you give on day 3, day 4, 25 milligram per kg, still these patients have a lot of mucositis. You give alkali rating agents to these patients, they have a lot of mucositis. So this group, there is a publication in which people try to change the regimens. In some patients, they decrease the dose of TBI. So they were using conventional Hopkins, fludarabine, cyclophosphamide with 200 cyclic grays of TBI, but day 3, day 4, 25 milligram per kg of cyclophosphamide. They tried to reduce the dose of TBI to 100 cyclic gray. They tried to omit cyclophosphamide before the transplant, but somehow in our experience, we have also tried each and every combination of this, but nothing is actually working really very well. So I would say that if you have a patient of Fanconi's, my personal opinion is if you have a patient of Fanconi's who doesn't have a full match donor, try to search for an unrelated donor, or you should think of doing a T-cell depleted, ex vivo T-cell depleted transplant rather than jumping on to PTCY based approach for Fanconi's patients. So 4 different regimens were used: cyclophosphamide at a dose of 10 milligram per kg, fludarabine 150 milligram per kg with TBI 200 to 300 cyclic gray, fludarabine omitting cyclophosphamide with TBI, fludarabine TBI with ATG, fludarabine TBI low dose 100 cyclic gray with rapid ATG. So what this group wanted to show is that with the addition of ATG, the issues went down. Though the mucositis rates were very much similar, whether the patient didn't receive rapid ATG or received rapid ATG. Hemorrhagic cystitis rates were almost similar. CMV reactivations were almost similar, but acute GVHD and chronic GVHD was less for those patients who received ATG along with flu-cy, TBI, and PTCY, as compared to those who didn't receive ATG as a part of GVHD prophylaxis. So this is a publication from India from Dr. Revati Raj, and what she has done, she has used almost a similar sort of regimen in which fludarabine along with low dose of cyclophosphamide, TBI 200 grays was used, and cyclophosphamide on day 3, day 4 with tacrolimus and omitting MMF, and she added NAC infusion. So according to Dr. Revati Raj, and from her experience, if you add N-acetylcysteine, the chances of mucositis goes down. So in her publication, there were 19 patients, and 16 out of 19 engrafted. There were 3 TRMs, that is 15.7%. 1% died before transplant because of sepsis, who had graft failure, eventually died because of sepsis. GVHD rates were quite high. 68% patients had acute GVHD. 80% of these had grade 1 or grade 2 skin or gut GVHD, and 20% patients had grade 4 GVHD. Chronic GVHD was seen in 25% patients, and overall survival, which I would say quite respectable when we say haplos in Fanconi's of close to 68.4% at 3 years. Similar publication from Saudi, in which what they did was they gave fludarabine with ATG, omitted cyclophosphamide, then TBI, followed by cyclosporin MMF and PTCY. And what they have noticed is 100% neutrophil engraftment. 3 patients out of 19 had acute GVHD, 1 had chronic GVHD at a median follow-up of 3 years. OS is 89.2%, phenomenal. But somehow, in our experience, we couldn't achieve anything closer to this even. Coming to sickle cell anemia, and sickle cell anemia been very close to my heart because there are a lot of people from Africa travel to us for sickle cell anemia transplant. So India has become a place for medical tourism, and people from different parts of Africa come to us for a transplant. And trust me, if you have a full match donor for sickle cell anemia patient, the chance of cure is close to 90 to 95% if somebody is less than 16 years of age. And if somebody is more than 16 years of age, still you can achieve a OS of close to 80, 85. But for people of African origin who don't have a full match donor, the probability of getting an unrelated donor is very, very bleak because of the underrepresentation of people of African origin in the registries. Then the only option left is a haploidentical transplant. And this publication talks about HLA haploidentical bone marrow transplant with PTCY expands the donor pool for patients with sickle cell anemia. So this is the conditioning what they used. Hopkins regimen, fludarabine, cyclophosphamide, TBI, tacrolimus or sirolimus, MMF, and PTCY. And out of those 17 patients, 14 were haplos and no TRMs, but though the engraftment was 100% in match sibling, engraftment in haplo was 62%. And later, realizing the fact that the engraftment is not up to the mark in the haplo patients, they added thiotepa, which reduced the rejection rates to 3%. So what we've been doing, let me come to that. We've been using, we are preferring father as a donor in sickle cell anemia. And what we do, we give thiotepa, flucide, TBI to our patients with PTCY, with cyclosporin and MMF. And out of 22 haplos, what we have done till now for sickle cell, our OS is close to 92%. So majority of our patients are doing very well. And this is the protocol what we've been using in our practice. Thymoglobin, total of, I would say, 4.5 milligram per kg per in 3 days. Thiotepa, 10 milligram per kg. Fludarabine, 30 into 4. Cyclo, 4.5 milligram per kg into 2. Followed by PTCY. And rather than, I would say, sirolimus, we use cyclosporin with MMF in our practice, and our outcomes are quite good. So regimen for the haplos in sickle, I would say regimen containing thiotepa plus 200 cyclic TBI and 400 cyclic TBI without thiotepa must be compared head-to-head in prospective randomized trials to know the optimal approach to cure patients. So there are some centers who are increasing the dose of TBI and are not adding thiotepa. We have not done that, but we are quite happy with what we are doing, with the outcomes, what we are achieving in sickle haplos. So I would summarize by saying that for Thal and sickle, target is to have a reasonable good quality of life. Mud and haplos are promising tools for these unfortunate kids, and experiences adding to the success stories for these transplants. For the aplastic target is to make sure engraftment is there and they don't have GVHD, less chemo, more immunosuppressive therapy is the key. Haplotransplant, I would say, maybe a better alternative to ATG with cyclosporin. In Fanconi's, similar sort of thing is what we want. Target is to make sure that engraftment is there and they don't have GVHD. Bone marrow failures have better chance of cure before they land up in MDS and AML. Less chemo and more immunosuppressive therapy is the key. And haplo brings future of hope because ATG and cyclosporin doesn't work for inherited bone marrow failure syndrome. So coming to our experience of haploidentical transplant in Fortis, so we all know that hematopoietic stem cell transplant is only curative modality for many benign and malignant disorders, and there is still a huge unmet need in transplant services in resource-constrained countries. And there are not many transplant units which exclusively cater to pediatric population in India. And also there is not much experience in doing unrelated and haplotransplants. And majority of the transplants in India are being done by oncologists. So here we share our journey of what we have done. So after I completed my fellowship from National University Hospital, Singapore, I joined a hospital by the name of Artemis. And at that time, there were two doctors, me and my colleague, Dr. Bhargav, who started the journey together way back in 2013. and we trained some of our nurses. We trained them in a way that they become nurse practitioners, so they can write down the chemo orders. They can write down the, I would say, antibiotic doses. So they were, I would say, one step ahead of just being the nurses. So we had a pediatric intensive care at that time. Other subspecialties were there. Radiation oncology was there in that hospital. So we at that time we requested the hospital to have a flow cytometer and apheresis service also, and we were actually outsourcing HLA to US, to histogenetics. And there was always a challenge of arranging funds in resource constrained countries like ours. So we did some campaigns. We did online campaigns. We took help of NGOs, and this is the most rewarding thing when you see smiles on these kids. So we are one of those centers in India which not only caters patients from India. We see a lot of patients from neighboring countries, from Middle East, from SAARC nations, from I would say from Africa, who come to us for transplant, for just one hope, for just one solution, which is a cure. And these are some of the happy faces. These are some of the patients whom we have treated in last 9.5 years. And this is the most rewarding thing for a transplant physician. I would say this is the wall of fame in my room. So the kids, when they go back, they draw something for us in a gesture to thank you. And this is where we are today. We have a big team trained in adult hematology, adult transplants, pediatric transplants. We have 9 doctors. We have 4 people trained in adult transplants. We have 4 people trained in pediatric transplants. We have, you have heard Dr. Neha, she is our ID specialist, and we have around 35 nurses in our BMT unit. So we recently celebrated 1,000 successful transplants. So me and Dr. Bhargav, we started this journey way back in 2013, and now in 2022, we have completed more than 1,000 transplants. And this is, I always remember this, my first haplo transplant, a patient from Iraq, from a place called Hilla, who came to us, who didn't have a full match donor. And we did his haplo transplant, and it's been 9 years, he's doing well. So with that, I would like to thank you all for a patient hearing, and I would be more than happy to take any questions if you have. Over to you, Arun.
So thank you, sir, for lucid and wonderful talk. So now house is open for any questions from any talk. So we now question and answer session is open.
Can I have a question? I have a question. Can I ask a question?
Sir, please.
Because Doa, wonderful presentation from NEH to up to 2022. You have did a lot, and you have contributed a lot to your nation, and it is amazing to hear for your presentation. And I have a question. Do you have experience regarding congenital dyserythropoietic anemia to any allogenic transplantation? And if you have experience, which type of conditioning you have used, and what is your experience? Thank you.
So we have done 2 transplants for CDA patients, and both were, one was matched sibling and one was unrelated. So we used busulfan cyclophosphamide with ATG based conditioning, and by God's grace, both are doing well. One is 2.5 years post transplant, and other one is 5 years post transplant.
Oh, thank you. Thank you. Highly appreciate it. Highly appreciate it. Thank you.
So any more questions from house?
So one question is in chat box. Ankit, please take the questions from that delegates group and put it in this, please. Okay.
So this we already discussed the CMV induced things. After that, there is no more questions I can see in the chat box.
there is a question in the chat box. I have put the question. If CMV induced marrow failure, graft failure, then no work, Belgan not working, ganciclovir more toxic, and after using cidofovir, graft failed. At this situation, do you have any experience the retransplantation of the individual? Because at the time there is no cell, graft failed, and after transplantation, they suppose more than 60 patient engrafted initially, and followed by CNV reactivation, graft failed, and all drugs failed, and cidofovir used and ganciclovir also used, but no work. After that, this time graft already failed. At this time, do you have any experience to retransplantation of the individual and any success? Have you any experience, anybody? Thank you.
Sorry, Dr. Mustafil, I didn't get your question. Can you just
just graft fill, graft after engraftment, day plus 60, CNV reactivation, graft lost of the individual of the patient, and I have declared a patient graft failure. This time, in this time, do you have any experience to retransplant of the patient?
Yeah, we have done, I would say, 9 haplotransplants, 9 second haplotransplants for people who have lost their graft, either as a primary graft failure or a secondary graft failure. It's always a tough situation. It's not easy to retransplant a patient because the patient is neutropenic, already underwent 1 transplant. Also, many of the families have cost issues. But to the best of our knowledge, we have done their transplant, and 4 out of these 9 are doing well. Though the outcomes are not very great, but that's what our experience is.
That time, do you have during the retransplantation, have you used conditioning, low dose conditioning like Fludra or something used for how many days, or 2 days or 3 days or 4 days? How many days?
Yeah, we have used different conditionings for different indications, but for all these patients, the conditioning what we used were reduced intensity conditioning and not a myeloablative conditioning.
Okay, thank you very much.
So, any more questions from house? So there is one question in the chat box. So just to confirm, cidofovir should be not used for CMV pneumonia or colitis or any other CMV disease. If Dr. Neha is here, if you could answer this question. So I think in talk, Dr. Neha already said cidofovir is good for the viremia phase, not for the established CMV infections like CMV pneumonia or colitis. So it is good drug for CMV viremia, but not for the established CMV disease. So CMV pneumonia is considered CMV disease. So I think that is the answer.
Hello, Dr. Bikas. I have a comment about this program. I think this kind of program it was very enjoyable, and it is very helpful as well. We attend many programs, so-called sophisticated programs, so many sessions, but practically the way we are discussing it is more applicable, and we need this kind of program at regular intervals. With I think more preparation and more attendees, so that and among our socioeconomic status, I think our patient demand, the financial constraint, and other constraints, we would be able to help each other. And of course, for this initiation, you deserve Fortis, especially you and Dr. Rahul Bhargava. You are the superb, and you are leading the session. And I was surprised to see the presentation from Pakistan. Dr. Thalassemia, I remember him. He was well known to me from King Faisal. He's one of the best our colleagues, and we lost him. And I think we'll keep in touch, and we'll extend our collaboration with any time we need. And I sometimes call you regarding some problems, and we'll help each other. And I wish all the success of this program, and thank you very much.
Dr. Arun, do we have any further questions?
No, sir, we don't have.
Okay, so if we don't have any further questions, we'll just wind off today's meeting. And I thank all of you who've been a part of this. I thank all the speakers, all the chairperson, and all of you who have attended, because what Dr. Abu Saleh just now said is that there are a lot of things which are happening in the West. But if we discuss among ourselves, if we share our experience, we can understand what is required and how we can improve our outcomes in SAARC nations, in low middle income countries. So with that, I thank you all, and we will definitely have another meeting next year, which is going to be the third SAARC meeting. We'll have a different theme for that. But in between also, we'll try to have some informal or formal meetings so that we can have sharing of knowledge, and we can learn from each other's experiences. With that, I thank you all and have a good night.
Yes, good night. Thank you.